Thank you everyone for inviting me to speak today and for being here to listen today. I'm going to be talking about supporting mental health in the autistic community and just sharing some new updates from our research on identifying contributors to depression in autistic adults. And this is a particularly important audience for me. I'm really grateful to be here today in particular, because whether you know it or not, we think of you at Spark as our partners in this work, and you have helped us out immensely, and we're just so grateful to each and every one of you. So my lab and my research program in general focuses on studying how and why autistic people become depressed, so that down the line, our end goal is to develop better treatments and work as a team with the autistic community to develop better treatments that address those pathways in particular. And I'm joining you today from Rowan University, as Dominique said, which is near Philadelphia, so not that far from the Spark headquarters in New York. And today I would like to present to you about how common depression is in the autistic community, why this is an important problem to engage with, what depression looks like in autistic people as far as we know, what may be some pathways or mechanisms by which it develops, and here I'm going to talk about some updates from our research, how people think that we should treat it, and finally, where do we go next, which I'm very interested to hear your ideas on where to go next to. But first, starting out with just some of this background. So in the scientific world, for a long time, researchers were concentrating only on core features of autism. So what is autism? How should it be diagnosed and treated? And luckily, things in the last 15 to 20 years or so have shifted. And now there's a dual focus of autism research on how best to support autistic people to thrive within this outside world that's not best set up to recognize the unique strengths and challenges of autism. And part of that shift in focus is understanding that autistic adolescents and adults are at heightened risk for mental health problems, likely in part because of the stress of this often intolerant world around them. So one study cited here pooled data from many different studies and found that autistic people were about 4 times more likely to experience depression in their lifetime compared to the general population. And these were the things here underlined, were the things that were associated with significantly elevated lifetime depression rates among people with autism. Being an adult, which sort of makes sense because as you get older, you have more chance to have experienced something in your lifetime. Being an adult, a higher measured IQ, using structured interviews versus less in-depth methods of asking people about their depressive symptoms, and getting self-report versus getting only other report about depressive symptoms. And when you look at these rates from this pooled study, this meta-analysis, this reflects, like for example, 40% lifetime rates of depression in adult samples. This reflects several independent research teams finding that when you put all these things together, often teams found 50 to 75% lifetime depression rates in studies of verbally fluent adults whose depression was assessed with structured interviews. So that means up to maybe even 1 out of 2 or 3 out of 4 autistic adults have had at least one depressive episode at some point in their lives. And that is really high and really concerning. And to put it plainly, depression is bad. Outside of the context of autism, depression is one of the greatest global contributors to lost person days of functioning. And then within the autism community, depression is associated with impairments in several areas, and it adds significantly to challenges that already exist for many autistic people. And it's also associated with greater service and medication use, greater risk of suicide, serious health complications. And there are even data to suggest that, that autism interventions and supports work less well when people are depressed. And finally, just again, this is our background here. Finally, this is really important to study mental health and autism because of your own voices calling for it. Depression and anxiety are repeatedly identified by the autistic community as high need, high priority for more services and more research. So what does depression look like in people with autism? Is it different from depression in the general population? And so here is what we think so far, based on, again, on your voices, on research studies, in particular from autistic adult samples. Autistic people who become depressed usually experience some or all of these sort of traditional features of depression. So this includes increased sadness or crying, feeling of emptiness, changes in appetite and sleeping patterns, increased social withdrawal and lack of motivation, as well as cognitive symptoms such as negative thoughts about oneself, feelings of guilt, failure, worthlessness, hopelessness. But then in addition to these traditional symptoms of depression, autistic people may be more likely to experience some atypical symptoms of depression, like changes to the quality or the focus or content of their interests or intensity of their interests. And that can go either way in terms of less intense or even sometimes more intense interests, or increased aggression or self-injury. But overall, the presentation of depression and autism does look more similar than different. And that's going to be important when we talk about, well, what do we do for treating this then? We conducted long standardized interviews with adults who were both autistic and currently depressed. And our team coded transcripts from 21 of those adults in terms of what they said about their depressive symptoms. So this is called thematic analysis of qualitative data. And our two collaborators listed, shown here on the slide, led this project, Gloria Hahn and Jessica Schwartzman, and they summarized our findings like this. So autistic adults seem to experience sort of classic depressive symptoms in line with existing medical frameworks of depression, with some distinct characteristics. So in those 21 adults, loss of motivation and withdrawal from life was very prominent. And it tended to co-occur with anhedonia, which is the word for a loss of interest or pleasure in things you usually enjoy. And that is sort of a core symptom of depression. This loss of motivation also was seen commonly in the presence of difficulties with sleep, often sleeping too much, and low self-esteem and hopelessness about the future. So that was sort of a very common presentation, at least in this small sample that we looked at very, in great depth. And then many people mentioned thoughts of suicide as a form of escape from rumination, anxiety, overwhelm, and hopelessness about meeting the expectations of others, self and others. And then there were atypical descriptions of depression. So ways that autistic adults tended to speak differently about their depression than what we see in conventional medical frameworks. These, we noticed, were primarily in the form of unconventional metaphors, so just describing the same symptom or traditional conventional symptom, but in a different way. Difficulty describing emotional experiences, which seems to overlap with, if you've heard the term alexithymia, it doesn't totally overlap autism, but many autistic people also have alexithymia, which is a difficulty sort of describing one's own emotions or labeling or characterizing one's own feelings. Let's see, where was I? So unconventional metaphors, difficulty describing emotional experiences, and significantly increased or decreased interaction with hobbies or interests, which I talked about on the last slide. And finally, our thematic analysis also revealed a few consistent themes about what seemed to lead to depressive symptoms in these people's own sort of their own understanding of how they became depressed. And that included the transition to adulthood as individuals navigated challenges at school and work, social difficulties, especially for individuals who desired more social and romantic connection. And finally, depressive symptoms were also linked to self-identity or difficulty accepting or understanding one's autism diagnosis or identity. And that was for about a third of the sample. And it was especially true of individuals with later diagnoses. So we're not actually going to talk today much about assessing depression in autism, but I did want to mention that one of our collaborators, Zach Williams, seen here, who is an autistic researcher from Vanderbilt University, as well as a Spark registrant himself. Zach undertook a validation study of the Beck Depression Inventory using data from approximately 2,000 adults, half of those being autistic adults from Spark. So if any of you listening today were part of that study, we thank you sincerely. And we are really excited for this chance to tell you about what your time and your effort led to. So the BDI is a commonly used depression questionnaire created within the general population. And Zach found that autistic adults answered BDI questions in comparable ways to neurotypical controls. And he developed a free online score calculator that provides autism-specific normative scores created in this large Spark sample. So thanks to your data, we now know that the BDI seems like an acceptable stand-in until an autism-specific depression instrument has been developed and validated. And we are actually working on doing exactly that. We have 2 new large-scale studies currently underway with Spark right now. So thanks in advance for those and for just in general making this work possible. So again, one of my primary research interests is understanding the mechanisms or pathways by which people with autism become depressed, in the hope that then that can shape how we go about treating depression in this population. Ooh, do I not have a, there we go. I had an animated title for this. There are several correlates or contributors to depression as identified in the general scientific literature on depression that also have been noted as being elevated or salient in autistic samples. And I've listed several of those examples in these colored domains here. So again, these are constructs that seem to be elevated in both depressed and separately autistic research samples. So, you know, first of all, we should study these and similar transdiagnostic constructs. We call transdiagnostic as being across these diagnostic groups. We should study these as risk markers or potential pathways to depression within autism. And trying to intervene on any one of these bullet points in any one of these domains will be important and helpful. But more than that, we need to recognize that individuals have diverse patterns and profiles in which factors across these domains likely interact with each other to put people at risk for depression. So I'm not sure why I have all these animated titles for my slides. Sorry about that. For the past decade, I've been really interested in repetitive thinking as a candidate treatment target for depression and autism. Because first, we know that repetitive negative thinking in the form of passive rumination is associated with the development or maintenance of depression in the general population. So repetitive negative thinking already associated with depression. And we're starting from the place of repetitive behavior as a core symptom domain for the diagnosis autism spectrum disorder. So repetitive thinking seems to be related to both depression and autism, but it remains relatively understudied compared to manifest repetitive behaviors, or in other words, behaviors that you can see, like lining up toys or repetitive motor mannerisms. So we asked Spark participants about their experiences with repetitive thinking in lots of different forms. And from a sample of 762 autistic adults in Spark, our collaborator, Steve Brunwasser, who's also at Rowan, ran SEM analyses, which is a type of statistical modeling that allowed us to test whether general repetitive thinking here in this diagram, whether general repetitive thinking was related to depressive symptoms on the BDI. And here we found a significant indirect effect. So that means that general repetitive thinking was associated with brooding, which is a passive, unproductive rumination on negative things. And brooding was associated with depressive symptoms. So this, again, this indirect pathway through brooding was statistically significant. But of interest, we also found a slight significant association in the opposite direction for the direct effect of general repetitive thinking on depressive symptoms, the C pathway right here at the bottom. And so to the extent that general repetitive thinking did not lead to brooding, it was associated with slightly lower depressive symptoms, and it might have even had a slightly protective effect. So again, indirectly through brooding, general repetitive thinking is associated with brooding, and brooding is associated with depressive symptoms. But there may be some protective things about sort of the non-brooding, or potentially the more autism-specific types of repetitive thinking. So we're interested in studying more about this relationship between different types of repetitive thinking and mental health outcomes. And another example of not all types of thinking being the same, 2 undergraduate researchers in our lab, Chris Pellegrino and Trey Scull, they studied that same Spark data set that I just told you about in the last slide, and they found that repetitive thinking that was associated with seeking solutions to one's problems, so you're thinking over and over again to try to solve your problems, or associated with savoring positive events, that type of thinking was associated with higher scores on quality of life in this Spark sample. So was engaging in one's strong interest with others versus independently. So these are just some of the interesting findings from Spark data. And we've actually got many others. And we continue to see Spark as one of our greatest resources and partnerships in studying mental health among autistic adults. So in terms of treatment, or treating depression in autistic individuals, we don't have many data from treatment outcome trials yet. We are way behind where we'd like to be in this regard as a field. Here listed in purple are some of the forms of depression treatments that you may have already heard of. So cognitive behavioral therapy, or CBT, is a highly effective treatment for depression in the general population when it is delivered well. And we do have randomized control trials that suggest that CBT works to treat anxiety in autism, though not much data yet for depression as an outcome. And then behavioral activation stems from CBT science, and it focuses on treating anhedonia. Again, that's the loss of interest or pleasure that is often associated with depressed mood. And behavioral activation works by promoting reinforcing activities, so building up activities and tasks that are meaningful in one's life, the kinds of things that in fact you tend not to feel motivated to do when you are depressed. And to my knowledge, BA, behavioral activation, has been largely overlooked in autism research, but I think it's a really promising lead for us because first, it's not based on talking or insight, so it can be applied to less verbal populations. And second, because research findings indicate that minimally structured lifestyles, for example, people with few set obligations or activities every day, those types of lifestyles are linked to poorer emotional health outcomes in both autistic and non-autistic people. So BA focuses on increasing engagement in both easy or pleasurable things, but also in harder but meaningful activities like building adaptive behavior. And then mindfulness-based therapies have really grown in popularity over the past maybe decade, or actually probably more than a decade. And there are a few small trials that have reported decreased depression and anxiety in autistic adults after mindfulness-based therapies. And finally, antidepressant medication. Sorry, I'm going to come back to acceptance and commitment therapy in a future slide. But antidepressants such as SSRIs are very commonly prescribed and used in the autistic population, not always for depression, but commonly taken among autistic people. But to this point, there's been no randomized control trial of their efficacy for being used specifically to treat depression in people with autism. So that is still to come. So this is just an overview about kind of what's out there and what's sort of big in treating depression in general. And then going back to the beginning with CBT, sorry, the slide looks kind of busy, and when I see it now on my screen, hopefully you can follow it still. CBT is just based on the idea that how we feel is directly related to our thoughts and our interpretations of things. So examining our thoughts, making them more explicit, and examining how accurate they truly are, that can be a really successful method of changing our feelings and behaviors that tend to maintain depression. So we are moving toward adapting and testing CBT for depression in autistic people. Again, it's been shown to work to treat anxiety in autism in several studies. And I just wanted to, I'm on slideshow mode, so I can't actually copy this now, but I'll try to put this in the chat later if I can. Remember, I said CBT works best when it's delivered well. The Academy of Cognitive Therapy.org has a Find a Therapist link within it where you can find people who have been sort of trained and certified in your area if you're interested. And that can help to get someone who really knows how to deliver this modality well. If you have found in the past that CBT has not worked well for you, you may ask your therapist to consider looking into some of the literature on best practices for CBT among autistic people. And so things like using more visual supports, using technology like phone apps, group therapy or family involvement, and then a new sort of in preparation work, a really lovely paper from Gloria Hahn that will be coming soon, gives concrete ideas about incorporating strong interests in therapy, in CBT-based therapy in particular. And then still kind of going back to that idea, what if one's own context is truly depressing? So people obviously can become depressed when they seemingly have terrific lives. They can also become depressed when the situation around them is truly objectively horrible. So that might look like ongoing abuse or other kinds of trauma, stressors associated with extreme poverty, and so on. And obviously there's no magic answer, but here's where I wanted to come back to the idea of acceptance and commitment therapy, something that we are really interested in looking into adapting for the autistic population. So instead of struggling against distress, in ACT, clients are guided to accept that some negative feelings are appropriate responses to certain situations, like ongoing bullying, for example, and yet that this appropriate distress shouldn't prevent them from moving forward in their lives. So trying to kind of work around, maybe bullying is a bad example because that's something we would want to be able to stop, but something that can't be stopped, like a chronic illness, for example, kind of moving around that to still have a meaningful, rich and enjoyable life. Okay, so ACT, let's see. Next, I just want to move just briefly to the idea of prevention of mood problems. This also is in some ways an intervention as well, in the midst of depression. So being someone with autism in a world that doesn't accept differences in social abilities, that can equal very hard work, and we know that. And sometimes when you work very, very hard every day with few or infrequent rewards, you just get tired out. So first of all, this is just a call for all of us to take up or continue this important, crusade. Really, we need to contribute in small and big ways to improving social acceptance of autistic people, because we've made huge strides in awareness and acceptance, but there's so much farther to go. Let's see. In terms of then on an individual or family level, in terms of prevention of mood problems, we mentioned briefly the idea of leading a structured lifestyle, structuring your time. I'm trying to sort of skip down because I think some of these things we're going to talk about late in some slides later. These are ideas in line with that behavioral activation to get out and moving and have, sort of have having meaningful activities and even obligations in your lifestyle. One of the other things that we need to focus on for prevention of mood problems is just awareness within families, particularly, or friend groups, chosen families, being aware of your loved one's mood, and especially consistent or persistent changes in their mood or behavior. And on the slide here, I say to have tempered vigilance, because those kinds of changes could be due to reasons other than depression as well. But going back up to this top bullet, it can be easier said than done to create and maintain a healthy lifestyle. So these, quote unquote, easy fixes, we understand they are not easy at all. Still, we want to think about things like, getting fresh air, getting exercise, taking your medication regularly if you have it, eating regularly and in moderation, and making healthy choices. Again, all of these things are hard. I can tick off every single one of these things as things I don't do very well in my life. So it's hard to sit here and say, oh, we should be doing this for our best mental health. But if you can really embrace this and commit to this, this makes a huge sleep hygiene. This makes a huge difference. Trying your best to create safe, fulfilling social connections. Again, not at all easy, but in addition to trying to create those opportunities, also working at keeping them healthy and uplifting, developing skills, accomplishing things, building in time for fun. These are all, kind of this high level sort of best prevention for mental health issues, focusing outward on helping others. And all of these slides are from a panel discussion that I presented. These sort of, as the slide format changed, you can see these tan slides came from this discussion panel that I presented with Doctors Alexandra DeGeorge and Brenna Maddox. And this was right at the very beginning of the pandemic, when things were so uncertain. And frankly, we were all scared. Still, these things ring true even now. Develop or practice this flexibility, living in moderation, practicing gratitude, tolerating uncertainty. And finally, just remembering that just getting by is okay too. So starting small, savoring successes, practicing gentleness, both with yourself and with others. And I like this quote from an autistic individual. Like many of us, I'm being productive when I can, and perhaps most importantly, I'm being kind to myself when I cannot. So back to this idea of prevention, this basic healthy living stuff is a very important first step, not an easy one. But because it won't always be easy, and there will be times when your kind of foot falls through the crack, so to speak, in terms of having a bad day or a bad week and getting down. Another thing I wanted to discuss is just being prepared with what I call an emotion regulation toolbox. in this idea, you would prepare personalized strategies ahead of time when you're feeling relatively well, or when your child is feeling well, if you're a parent in the audience today. List out what helps you to relax, feel less anxious, feel more invigorated, what usually makes you laugh, what calms your negative thoughts, etc. And so you kind of have this menu that then when you notice yourself slipping down into a sad, empty, anxious, otherwise negative mood state, or you notice that in your child, you try to choose off the menu of these tools that you created for yourself. And again, you don't feel like choosing at the time. That's the whole problem with depression. You're not motivated to then do these things. But if you can sort of get into a habit of sort of forcing yourself to try 3 for 5 minutes each. So this is a generic example on the slide, but you would be specific in your own toolbox. You'd write down phone numbers of people you can call, places that you can go that have beautiful views or happy memories for you, specific episodes of shows that make you laugh, or specific songs that help to change your mood, gathering pictures of interesting things or special people, and so on. With clients in the past, I've also included sensory tools. So set a timer to watch a ceiling fan for a certain amount of time and then rate your mood again, or watch flowing water to try to get into a calm space, or distress tolerance tools that come from an area of therapy we haven't talked about, dialectical behavioral therapy, or DBT. So if you are someone who feels like cutting to stop the feeling of numbness or negative affect, you might stick your hand in a bucket of ice water for 1 minute, and then rate your mood again, that kind of thing. So get creative and personalize these. Set this up when you're feeling okay. And then just know that different responses or activities in your toolbox or on your menu might be more or less effective for different situations. And we haven't talked much about the minimally verbal population, and truly this is a group of autistic people that tends to get overlooked in a lot of mental health research. But this is also a significant proportion of the autism population, and it should be sort of a primary versus a special consideration. Let's see. So here we would be interested in behavioral activation strategies as well, including increasing self-help skills and increasing social exposures. I have a flyer at the end of this talk about things that we're recruiting for, but here I just wanted to mention that in our lab, we're piloting a nonverbal eye tracking task to see if we can index depressive symptoms in autistic adults with limited or no spoken language. So we are definitely recruiting adults in that category. If you're interested, please contact SEAL, spelled with an H, SEAHL, at rowan.edu for more info on that. And finally, kind of putting this all together in terms of next steps. So to sum it up, depression is concerningly common in autistic people, and it has a negative impact on all kinds of health and quality of life markers, and people want help with this. We didn't really discuss assessing depression or diagnosis of depression in autistic people today, but know that that can be tricky because of symptom overlap between autism and depression, and difficulty communicating about internal states, lack of validated measurement tools, etc. Some treatments for depression show promise, but we need much more research in this area. And again, we are hoping, I'm really grateful to have had this opportunity to tell you about some of the things that we're pursuing now in our lab, because we're hoping that this may lead to identifying some more precise treatment targets to build up or develop or adapt treatments around in order to help people with autism and depression in the future. And in terms of next steps, here are some things that I think hold a lot of promise. Work is already going on to provide better depression measurement tools specifically for the autistic community. This is going to help both research and clinical practice if people can be identified sooner and we can ascertain who needs help or who is at risk. Again, we have two large-scale studies going on in Spark right now, one that just rolled out last month and one that is still to come but is in the works. And so we really appreciate your support with that. But better measures, we hope, really will lead to better research. We also need to focus on particularly vulnerable subgroups within the autistic population, such as gender and sexuality minorities, those with limited spoken language, and children who often are not necessarily, again, where more of that research or clinical focus is about autism itself versus mental health in children and adolescents. We should also build out research on many different potential treatment targets. So I told you about a couple that we are really interested in, but we need a lot more. So things like camouflaging, autistic burnout, if you've heard that term, supporting employment and romantic and other life goal fulfillment. We need to think about diverse potential causal contributors. And finally, we need to get more people on board to work on this problem, sort of mental health in general in autism, including the autistic community itself. So not only do we need better interventions developed, but we need to work together to improve access of the autistic community to the treatments that already exist. And I'm going to talk about that next. This is my last slide here. So some of the things that we need to do will take a really long time to accomplish, such as changing our society. We need wide-scale social change to accept and celebrate our differences and to respect and support all people. And that will probably have huge, have a huge influence on mental health in autistic people, but it's also something that is such an enormous task to truly change the world or change society. In addition to doing this and to really committing to that long-term, careful, methodical, slower work, we also need to be working on the now, including providing social support to individuals we know who need it within our daily lives and our own sort of small microcosm, our own worlds. We also need to encourage clinicians who already know how to provide depression treatment. We need to find ways to communicate on a wide scale that these clinicians don't necessarily need specialty training in autism to accept an autistic adolescent or autistic adult onto their caseload. So depression is more alike than different on and off the spectrum. And autistic people need and deserve this equitable access to mental health services right now. So that's one of the things I'm interested in talking with you about, your ideas about how we do that, because that's almost like a public service announcement of getting existing clinicians to understand that they're not, they feel like they're being sort of ethical and practicing with competence to say, that they're being ethical to say, I don't think I can practice competently with this person. But instead, it just means a lot of people with autism are getting kind of turned away from services that they really need. Let's see, let's check the time. Perfect. So with that, I think I'm going to just thank you again for your attention today, and very sincerely for the work that you have already done in making this and other research possible by being part of Spark, and other things you do to participate and support our shared partnership across different types of stakeholders in this community. I thank you all, and here is an acknowledgement slide. I use this everywhere for all kinds of talks, and you see Spark is right here front and center, so it's extra special that we get to present it here to you. And I will just leave this up while we're getting questions ready. Please do contact us If you are in the area and you sort of recognize yourself as fitting into any of these eligibility kind of groups, again, we're SEAL, SEAHL at rowan.edu. And I guess, Dominique, I'll turn it back to you. Is that right?
Yes, thank you so much, Dr. Gotham. I will facilitate the Q&A, and just a reminder for everyone who's attending, you can continue to submit your questions in the Q&A box as we begin this portion of the webinar. So a question that came through when you were speaking earlier in the presentation about the Beck Depression Inventory. So does the fact that a lot of autistic adults may be medicated due to other lifelong challenges, would that affect the validity of data related to the BDI?
That's a really interesting question. Thanks for whoever posed that. So you're right, there are a lot of people who take meds for all sorts of things, including, as I mentioned, who take actual antidepressants, but not necessarily for depression. We think about this kind of similar to assessing autism itself. Like if you are doing an assessment or diagnosis for autism, you want to see what that person's actual behaviors are like. And you might make an autism diagnosis even if you felt like there was some other reason for those behaviors. We can basically, at this point in history, just call it like we see it. It's a similar thing for the BDI. So if you were taking meds that changed your mood for whatever reason, we hope that would be picked up on your actual report of your mood on the Beck Depression Inventory or any other kind of inventory. And we might not expect, sorry, I'm losing my train of thought for a second. If the mood symptoms aren't there for whatever reason, the Beck can't tease out why they're not there, but we want it to pick up what is and what isn't there. So I don't know if that makes sense as an answer to you, but I guess I'm trying to say that we're hoping that wouldn't truly affect the validity of it. Even if there was some sort of behind the scenes reason that the mood symptoms changed themselves, that would be sort of a different part of the clinical or research picture that you would not rely on a screener or a questionnaire to get at that.
Great. And then one thing that I think came through from a few people, are you able to speak to DBT a little bit more? I think some people were just curious about what that looks like.
Yeah. So DBT is a really cool, interesting modality. I will say right up front, I don't know it well, as it was created initially specifically for the population with borderline personality disorder. So people who have a lot of emotional lability, that means like quick changing emotions, but also often have, sort of tumultuous relationships, often have a lot of suicidal ideation or kind of impulsivity around sort of mood and relationship kind of states. DBT, the reason that DBT seems like a wonderful thing to kind of borrow from and use in lots of different clinical populations is because at the heart of it, you are looking at emotion regulation strategies. So again, I'm not a DBT expert, but I would sort of recommend that people look into it further if they are interested in those kind of types of concrete strategies that help to build up distress tolerance. So when you feel in the moment like you're just so overwhelmed with these negative feelings, you can't use your menu, you can't do your, you can't think through cognitively, and examine your thoughts for accuracy, all that kind of stuff that's really hard in the moment. It's sort of one of the things, not the only part of DBT, but one of the things that I really like to dip into and share from is that idea of these really concrete sort of coping strategies for building up just the ability to tolerate the distressing feeling.
Great. And then to your knowledge, has EDMR been used in assessing or treating depression in the ASD community?
Interesting. I would think definitely in treating. I don't know of specific research off, like I can't sort of cite studies off the top of my head, but I would be surprised if that hasn't been looked at. I know just anecdotally, I don't use it myself, but anecdotally, I have talked to people in clinics who say they think that they really like it and think it really works for helping to, especially if we're starting to think of some of the experiences that autistic adolescents and adults face on a daily basis as being sort of a form of ongoing trauma. That will be, that is something that has like a lot of evidence from the trauma-based literature. So in terms of using it for assessment, I don't know of anything like that. But in terms of treatment, I think there's, definitely promise there as well.
Another interesting question that came in. I mean, they've all been interesting, but another interesting one. So are you aware of any research that's related to autistic female adults with depression and premenopause? Are there any sort of?
Ooh, I don't, but that, as you know, as a 44-year-old woman myself, like this is the time I'm starting to be interested in those kinds of topics. And I do think that would be fascinating. I think we are, I just feel really grateful that we are, from the time I was a graduate student to now, I feel like there's just so much more focus on autistic women in general. One of the things I didn't, sorry, I'm going on a tangent. I will first answer the question to say, no, I don't know of any research like that, but I appreciate the question. And I think that's a terrific direction to go because certainly, certainly hormonal changes have, play a big part. I do know of people who are interested in or who have been studying hormonal changes and mental health in the autism spectrum, particularly in girls, but in the developmental period of puberty versus perimenopause. So I do think all of those, have so much, hold so much promise. Obviously, there's just more things to study than we have people to do it. But these are all great points. I was just the tangent I was going to go on. Oh, I know, was just that idea of, it is really so promising that we do have so much more research on women in general and later diagnosed individuals. And on that note, one of the things I didn't make time to say, but wish I would have in retrospect, is that in the BDI study from Zach Williams that I presented on, which was a Spark-based study, one of the things that I think is just so important and interesting is that we also looked in response to what we thought would be, kind of reviewers pushing us on the Spark sample. We had a predominantly female sample and a predominantly like adult as first-time diagnosis of autism. And so that is different in those key ways from sort of a male skewed and early childhood age of first diagnosis that we commonly see in convenience samples in research. So samples that come through sort of university, big clinics, things like that. And were we going to get sort of pushback that was somehow fundamentally different? I think what we have noticed in our research is that, well, two things. One, statistically, it was not fundamentally different. When we looked at our findings on the BDI by age of first diagnosis and by gender, we were not seeing important, meaningful differences. So really, it was, it would have come out either way in the same direction, whether we had the whole Spark sample as it was, or sort of looked only at that kind of early diagnosed, more predominantly male sample. But the other thing I'm really grateful for is this idea that, now later diagnosed and people across the gender spectrum we're really realizing that this is autism. This is what autism looks like. And that I think is really encouraging. So our sort of, myopic focus on, like a 4-to-1, male to female ratio, and or 5-to-1 even, and sort of that early childhood ascertainment. That is a really important part of autism, but it's not the only part of this community. And there are a lot of benefits to understanding who's out there and who and who needs help and sort of wants to be involved in this. Sorry, I'm talking too much. I'm going to stop so you can get more questions.
No need to apologize. I think this is really interesting information for all of us on the line to have. Another question that came in, can you talk about what is, if any, the relationship between depression in autistic individuals and nutrition and eating habits, and if there's correlations there?
Yeah, I mean, I don't really have data because this is not my area. I can't pull out sort of numbers for you, but I do know that in general, not just in autism research, but in sort of scientific research in general, I think people are more humble now and more open-minded about true mind-body connections in ways that it seems like, again, 20 or 30 years ago, that was not something people maybe wanted to really get into, or that seems to, like, I don't know, like, not scientific enough. And now I feel like we really have a good sense that, very limited diets and poor nutrition clearly has an impact on mental health. So again, it's one of these sort of linking things. Like, we know that that's a problem in depression. We also know, especially for a lot of children on the spectrum, I'm sure as well as adults too, but definitely we hear a lot from families with children who have very, very limited things that they'll eat. So that is a risk. And I guess I don't know if you want to restate the question, Dominique. I'm not sure if I heard the question or I'm answering the question itself, but I don't really know specifically like a number to quote about this is the connection between that, but we just know that this is a risk factor. So poor nutrition or very limited diets.
Yeah, I think based on the question that came in, I think that gets at the crux of it. And then I think probably have time for like two more questions, and I have a couple that I think will be nice ending notes here. Mm-hmm. So first one, just generally for parents or caregivers of an individual with autism, the parent themselves has a history of depression or severe anxiety. Is there a higher probability that their autistic child may present these mental health issues as well? Or is that something you could speak to?
Yeah, great question. So we do know that there is a hereditary component of mood problems. So, that child may, is likely, or sorry, I don't want to talk on an individual level, but in aggregate, children of depressed parents do tend to have, somewhat increased risk for depression. So that or anxiety, that is, sort of a known finding. However, there can be environmental, so it's kind of back to that sort of nature versus nurture thing. Is it just a genetic transmission that puts these kids at greater risk, or is it instead /and are there environmental risk factors? And I don't know this literature very well, but from what I remember, there's some movement to be looking at sort of positive affect in kids who are raised by depressed parents, and that it might not be that those kids have greater negative affect, but they might have reduced positive affect. So please don't quote me. This is not saying, this is not prescriptive, like this is what you should do, but I just wanted to share that finding in the sense of thinking holistically about, like, if you are a depressed parent, what can you do for your child to protect your child? And it sounds like there's some reason to believe that, and certainly couldn't hurt. One of the things that we could try to experiment with is just making sort of those meaningful, again, kind of like along the lines of behavior activation, sort of building up positive, meaningful, valued activities in that child's life to try to see if you can kind of support and care for and nurture the positive affect in growing children as well.
Great. And then I think with this last couple minutes, this might be a nice note to end on. Do you have any advice just in general for autistic individuals who are struggling to find therapists that are well versed in autism? Are there maybe places that they could look, or things they should be looking for in their therapist?
Yeah, that's a great question. That's actually a really hard one to end on, because as I was talking about toward the end, that I think is something we really need to band together as a community and try to get the word out to therapists that things are more alike than different. People need to be seen. And so in terms of finding someone with expertise in both, that's pretty difficult to do. And it's hard for me to sort of think about it at the, if you're in the area where you can go, if you have geographical sort of accessibility to like a university training clinic or something like that, you might start there. But for a lot of people, this would have to be something telehealth related. I'm just going to stop there because I know you said you wanted to stop a minute before, if possible, Dominique, just to say it's not easy. But my take home would be, find a therapist who is well trained in the actual, like, for example, if you're interested in CBT, find someone who really knows CBT well. And if you have to, bring things to them to say, this is the literature about, working, very small adaptations to work with an autistic client around, using CBT. And that's not fair that you'd have to do that, but better than the alternative of not being seen.